let me give just a brief introduction of Professor Andrew Levey. Professor Andrew Levey is a Chief Emeritus William D. Schwartz, Division of Nephrology, Tufts Medical Center, and is also a Professor of Medicine, Tufts University School of Medicine. He's also Dr. Gerald J. and Dorothy R. Friedman Professor, Emeritus, Tufts University School of Medicine. And he has also got several awards, including President's Award, Garabed Eknoyan Award, and W.Hume Award reception from National Kidney Foundation. So Professor Andrew Levey has got interest in research, including measurement and estimation of kidney function, epidemiology, and clinical trials in CKD. And for the past 20 years, he has been at the forefront of the development of equations to estimate glomerular filtration rate from serum creatinine and cystatin C and novel filtration markers using MDRD and CKD-EPI. The moderators, Dr. Robert Kierusobila, for the first time is moderating this session. Dr. Robert Kierusobila is from Uganda. He's a nephrologist and a fellow from Yale University. And he's also a senior lecturer at Mulago Hospital, the teaching hospital of Makerere University in Uganda.
So the topic I picked is to go over current CKD guidelines and application of GFR estimating equations in Africa. So for the goals of the presentation, I was going to start with a little bit of the US and worldwide burden of kidney failure and the availability of replacement therapy. And I was going to review some data published in Lancet and USRDS, talk about the KDOQI 2002 guideline, the update by KDIGO in 2012, talk about kidney failure replacement therapy and early stages of CKD in Africa from a global burden of disease study in 2017. Thanks to Nikhil, we distributed a survey on estimated GFR in the Africa Healthcare Network. I was going to talk about how your practices compare to the KDIGO guideline recommendations for GFR estimation. And I was going to talk about the accuracy of GFR estimation equations in Africa, and then have a summary and conclusions. I think my wheelhouse, so to speak, it has to do with the estimating equations and the guidelines. So I will very briefly go over the epidemiologic data just to give you an idea about it. So kidney failure in the US is characterized by an increasing prevalence, a high mortality. For dialysis patients, it's about 14% per year, and an extraordinarily high cost, totaling 7% of Medicare fee-for-service expenditures. Even though treatment is guaranteed in the US for virtually everyone, there's a disproportionate burden of CKD among the older, the male, African American, representing, I think, in great part, social disadvantage and increased burden of high-risk genotypes in the APOL1 gene, which is in high prevalence in Western Africa, higher incidence in Hispanics, and higher incidence in diabetics. That's even with treatment provided by the government. The international comparisons from the USRDS are shown here from data from 2016, and you'll see the only country in Africa that they have data from is South Africa. And regarding the incidence and the prevalence of treated ESRD, South Africa is down here at the bottom, okay, in both of these slides, indicating that there's quite a bit of variation, but whatever the causes of variation, we see less penetrance of dialysis treatments in Africa. And in South Africa, the only place with the data, less than the rest of the world. This was reviewed in more detail a couple of years ago in the Lancet in 2015. Here's their map of the world. And as far as patients per million receiving kidney replacement therapy, Africa is shown here. And there's a lot of countries in Africa where there is no data, right? But the ones where there are data, here in Eastern and Western Sub-Saharan Africa, the availability of treatment is less than in South Africa. Right? And for many parts of Africa, there simply weren't data and projections were modeled. This slide has pretty pictures. It shows that the proportion of people receiving renal replacement therapy in Africa is lower than in the other continents, with the exception of Oceania. And when you multiply this through the population, this is the numbers of people receiving kidney replacement therapy. Throughout the world, there's a big stratification by income. So the availability of replacement therapy is smallest in the low-income countries, and as we move up the gradient into high-income countries. Therefore, treatment in the low-income countries accounts for a tiny fraction of treatment in the world. And this shows changes over time for the world, but changes over time stratified by the continents that are shown before. And once again, there's Africa is low and making only slow progress. They compared this, however, to what they called the need for receiving kidney replacement therapy. And they estimated the need both by a conservative model and a high estimated model. And you can see that in Africa, here's the same numbers we saw before, 81, the need is estimated to be much higher than that by either the conservative or the high resource model. So there's a large unmet need, as you're well aware. I'm not telling you anything that you don't know already. Going now to guidelines. The guidelines for chronic kidney disease, both the KDOQI guidelines from 2002 and the KDIGO update in 2012, were developed to try and identify earlier stages of kidney disease to prevent kidney failure. We developed a conceptual model for CKD where kidney failure is the end stage. Earlier stages are low GFR and kidney damage. And at any stage, there can be complications which lead to death. And the high rate of death among people with earlier stages of kidney disease leads to the finding that you'll see later is that there are many more people in this stage than in this stage. Kidney failure, therefore, will represent the tip of the iceberg for ESRD. Kidney outcomes are shown on the horizontal axis with progression this way, remissions this way, and complications are shown here. Metabolic and hormonal complications, these are the uremic complications, but we also now recognize cardiovascular disease, drug toxicity, and others, including infection, cognitive impairment, and other common diseases in the elderly. CKD, therefore, can be defined as markers of kidney damage, a GFR less than 60, or kidney failure, which was defined as GFR less than 15 or dialysis for 3 months. And KDIGO classified, KDOQI classified this into 5 stages by GFR. At GFR less than, greater than 60, the disease is identified by markers of kidney damage, such as albuminuria. A controversy arose because of the high prevalence of earlier stages of CKD, more than expected, and therefore the chronic kidney disease prognosis Consortium was born, which analyzed data from 45 cohorts, 1.5 million people at the time, relating outcomes of CKD, including all-cause mortality, cardiovascular mortality, ESRD, AKI, and progressive CKD, to GFR, right? Here's GFR of 60 in each case, and albuminuria. This is 30 to 300, or so-called microalbuminuria, greater than 300, macroalbuminuria to no albuminuria. And you can see that both low GFR or higher albuminuria are independent risk factors for these outcomes. And that led to the further classification by KDIGO to classify by albuminuria category as well as GFR category, to split the G3 category into A and B. And you can see that that's quite reasonable because there's a great heterogeneity in risk in what we used to call stage 3 CKD. And we proposed the classification system, which included not only cause, but GFR category and albuminuria category. We call this the CGA classification. This led us to have operational definition of CKD for epidemiologic studies and public health programs. We called kidney damage ACR greater than 30, an estimated GFR less than 60 for decreased GFR, and eGFR less than 15 or dialysis. And we retained the 3 months definition, but in epidemiologic surveys, this is often not applied because repeat measurements are not available over 3 months. And when we used the NHANES survey in the US to determine the number of people in each category, we found that 11.5% had CKD, that's everything but the green. That among people with CKD, the red, or the high-risk categories, 9%, 18% for the orange, and 73% for the yellow. So most people with CKD have moderate risk, okay? A minority have very high risk, and these are, of course, the ones that we're most concerned should come to nephrology attention. There was a debate about the importance of CKD stage 3, which was 6.2% of the population. I think this debate continues, but it's about the importance of category G3A and category A1, which still represents 3.6% of the population, and particularly among the elderly. I continue to feel there's increased risk in this subgroup, and therefore it should be classified as CKD, but there's a very vocal minority of people who disagree. Now, the Lancet published a study from the global burden of disease based on their 2017 data. This was published in 2020, and they applied these definitions worldwide and concluded that the prevalence of CKD is almost 700 million, representing 9.1% of the world's population, with 31% due to diabetes. They estimated that the mortality from kidney failure was 1.2 million per year, and an additional 1.4 million due to cardiovascular disease in people with CKD. And this represents 4.6% of total mortality and is number 12 on the list of causes of death in the world. And they have a statistic called the disability adjusted life years. A disability adjusted life years is the sum of years lost to disease, or excuse me, years of life lost due to disability and years of life lost due to death. And they estimate almost 36 million DALI due to kidney failure and an additional 25 million due to cardiovascular disease. And in each dot on this diagram is one of the nations in the world, and this represents the relationship of socio-demographic index with higher numbers, meaning higher income, and this represents the DALYs, right? And you can see that they are higher in low-income countries, right? And these are the different regions of the world which are listed here. And in Eastern Sub-Saharan Africa, right, the prevalence of CKD was about 9.8%, similar to the rest of the world. The mortality is 37,000, and the disability adjusted life years is about 1.4 million due to kidney failure. And this string of dots here represents the countries that the Lancet groups into Eastern Sub-Saharan Africa. This shows the age standard disability of life years rate by geographic area. And this shows it due to kidney disease, and this shows it due to cardiovascular disease and gout. And here is, again, Eastern Sub-Saharan Africa, fairly similar to Central Sub-Saharan Africa and Western Sub-Saharan Africa. So these issues of the Lancet have lots of good data. Now, Nikhil and Lloyd were kind enough to distribute a survey to some of you on the results on how you estimate GFR in your clinical labs. And my research associate, Zui Chowdhury, compiled these results. And briefly, we had 47 survey respondents. The countries of residence are shown here, the most from Tanzania, Kenya, and Nigeria, and a scattering of other providers. If any of you are on the phone who completed the survey, I want to thank you very much. This is fun information to get. This was the breakdown of the jobs of the survey respondents. And you can see that 89% are reporting information from hospital clinical laboratories, and 11% were reporting information from their commercial lab. We've broken the rest of the results down into whether the results are from hospital clinical labs or commercial lab. And first we ask what type of serum creatinine assay is used. And not surprisingly, a lot of people don't know, right? Among those who knew, there's enzymatic assays, right, are as frequent or more frequent than the kinetic alkaline picrate assay. This assay, but either assay can be standardized to the international standard. And some were reporting another kind of assay. When asked whether the measurement procedure was traceable to the reference procedure, meaning whether it was standardized, most of the time, yes. Sometimes people didn't know, and rarely no. So this is good. Either assay can be standardized, and most commonly you're reporting that the assays are standardized. We asked whether eGFR or estimated creatinine clearance was reported when serum creatinine was measured. And we asked to indicate whenever serum creatinine is measured, and the commercial labs usually follow this, which I think is a good idea. But the hospital clinical laboratories didn't do it whenever serum creatinine was measured, but did it on request or didn't report estimated GFR or estimated creatinine clearance alone, but didn't report the estimations at all. They just reported creatinine. And some people didn't know. The GFR equation was in use in commercial laboratories. It was most often the Cockcroft-Gault formula, some with the CKD-EPI equation and some with the MDRD study equation. In hospital clinical laboratories, it was predominantly the MDRD study equation, some use of CKD-EPI, infrequent use of Cockcroft-Gault or any other equation. And many people didn't know. The question was, how are values reported if the eGFR is greater than 60? Estimation equations vary in their precision above 60. The CKD-EPI equation is good. The MDRD study equation is not meant to be reported as a numeric value greater than 60. Hospital clinical labs generally reported it as a numeric value, commercial labs, whereas there was variation in hospital clinic laboratory, some as greater than 60 and some as a numeric value. And then how's the African American race coefficient used? This is a coefficient that's in the MDRD study and the CKD-EPI equation. So a large number of hospital clinical labs or commercial labs or respondents said that their lab reported Africans are considered as African American, where a smaller number said that Africans are considered as non-African American, and some people again didn't know. And I'll have comments about all of this. So here's what the KDIGO guidelines say to do. KDIGO talks about GFR evaluation, gives general recommendations regarding creatinine, talks some about confirming creatinine if using cystatin, talks about how to estimate using cystatin, and again gives some recommendations regarding decline. We'll just review the general recommendations and those about creatinine. So the premise is that GFR is the measure of function we wish to assess, that eGFR is more practical than mGFR, that we want clinical labs to report eGFR when we measure the filtration marker, and we just want a single equation for labs for each marker. So the idea that some labs are reporting CKD-EPI versus MDRD versus is not really what the guidelines are recommending. So the guidelines recommend using serum creatinine and an estimating equation for initial assessment, and then additional tests such as cystatin C or a clearance measurement for confirmation. Well, if the guidelines are recommending that it should be used for initial assessment, then we think the labs ought to be reporting it. All right, this is clearly an action that could be taken for your labs to report this when you order the serum creatinine. The guidelines recommend to use eGFR creatinine rather than the serum creatinine alone, but to understand the clinical settings in which it may be less accurate, such as the non-steady state, factors affecting the non-GFR determinants, such as extremes of muscle mass or diet, inhibition of tubular secretion, higher GFR, as we mentioned, or something that interferes with the assay. This should be what we nephrologists know about. We recommend the clinical labs should measure creatinine using a specific assay with calibration traceable to the international reference method, which is IDMS. They should report the eGFR creatinine in addition to serum level and specify the equation used whenever reporting it. So that way we should all know. There shouldn't be don't know. We recommend that clinical labs should use the CKD-EPI equation. An alternative creatinine-based equation is acceptable if it's been shown to improve accuracy. The reason it's not good enough just to be as good as CKD-EPI, because then we would be using multiple equations around the world. We want to use different equations from CKD-EPI only if they're better. They did recommend racial and ethnic regional modifications may be required for creatinine. Okay, so the guidelines anticipated that this could be a factor. The basis for recommending CKD-EPI over MDRD was shown in our paper here in 2009, where we showed that the difference between measured and estimated GFR was greater for MDRD study than for CKD-EPI. No difference is the horizontal axis here at 0, and closer to 0 is less bias. A positive bias is an underestimate. So MDRD underestimates the GFR at higher levels. And this is a particular problem right around 60, where we define CKD. And this is much less a problem with the CKD-EPI equation. there's still a lot of spread in the data. This represents imprecision, but it is largely an unbiased estimate. And we also published our cystatin equation. And I'll just tell you that the cystatin equation turns out not to be less biased, more precise, or more accurate than the creatinine equation. However, when you combine them together, you do have greater precision. A lower number is greater precision, and less and higher accuracy. A higher number is greater accuracy. So we do think that this is a useful confirmatory test. It costs more and it's less available, but I think that it's coming. For your interest, the coefficient for creatinine in the creatinine equation is about the same as the coefficient for cystatin in the cystatin equation, but age is closer to 1. The age coefficient is closer to 1 for cystatin. The sex coefficient is closer to 1, and there is no race coefficient. So cystatin is more highly correlated with measured GFR than creatinine. But once you add age and sex and race, creatinine and cystatin perform pretty equally, as I've showed you. When you put them both in the equation, the coefficients for creatinine and cystatin are each about half, whereas the coefficients for age, sex, and race are intermediate here. You'll excuse my dog who wants to be part of the presentation here. Hold on just a minute. One of the disadvantages of working from home with COVID. Excuse me. So this gives you an explanation for why the combined equation is more precise. If there's an error due to creatinine, it's smaller in the combined equation than in the creatinine. And similarly with the cystatin equation, it's smaller if it's combined. Now, how could ethnicity affect the accuracy of GFR estimates? Well, the ethnicity could cause differences in true GFR, measured GFR, the non-GFR determinants, or the filtration marker assays. For the non-GFR determinants, I think the issues relate to the sieving coefficient, generation, tubular handling, or extrarenal elimination. I think it's mostly generation, although each of these factors could be investigated. I think it's mostly generation, and it has mostly to do with muscle mass. However, we should be cautious that differences in the accuracy in GFR estimates between studies of different ethnic groups may reflect differences in the study design and the methods rather than the ethnic differences. And therefore, we should appreciate that if we modify the equation by local coefficients to overcome these differences, we may be attributing to ethnicity these local coefficients when it really has to do with study methods. Now, this doesn't mean that local coefficients are not important. You should view them as calibrations to the GFR equations. In Asians, for example, the CKD-EPI collaboration equation may require an ethnicity coefficient to adjust the estimated GFR to an Asian reference GFR lab. This seems to be less so for cystatin, right? Probably because cystatin is less affected by muscle mass. Now in Africa, there have been limited studies, but by this time there have been a number of studies, and there have been studies with measured GFR in these countries in Africa. And what they've shown is that for African Blacks, the African-American coefficient in the MDRD and CKD-EPI equation is not required. For whites, there's no modification of the equation that's required. And in South Africa, there's no need for the African American coefficient in blacks. This is for the creatinine equation. So I would encourage you not to use the African American coefficient in Africa. In cystatin equation, no modification appears to be necessary. There are studies going on to improve kidney function estimation in sub-Saharan Africa. A review here by Fabian suggests that there has been there are a lot of flaws with the current studies, and therefore suggests new studies. And there is a new collaboration to evaluate methods for GFR estimation in sub-Saharan Africa. So a brief summary. We've talked about the guidelines regarding the CKD definition and classification and prognosis, given a brief summary of epidemiology, documenting what you know is a large unmet need for kidney failure treatment in Africa. There are limited data for earlier stages of CKD in Africa, but it seems to be just as prevalent as anywhere else in the world. I hope I've shown you that GFR estimation is important for clinical practice and public health. Briefly summarize the guideline recommendations for GFR evaluation. And the survey suggests that there's room for improvement. And I would encourage clinicians to collaborate with their laboratory medicine colleagues to improve the state of creatinine assays where they're not standardized, to implement GFR reporting where GFR reporting is not being done, to use the CKD-EPI equation preferentially compared to any other equation, and not to include the African American coefficient for application to African blacks.
And thank you very much for agreeing to present to us. And we take this opportunity to thank you for the great work you've done for the field of medicine, especially in ensuring that we measure the kidney function correctly throughout the world. Much appreciated. So to our attendants tonight or this morning, for those who are coming from other countries, we would like to open the floor for several questions. You've had the wonderful presentation by Professor Levey. And so I think this is a clear and opportunity for us to be able to learn more about how we can better understand kidney function measurement. So with that, I would like to open the floor. You can send in through the chat. I'm not able to see the hands. I think the moderator would help, or you could just unmute and ask directly the questions to Professor Levey.
Just a question, Sir Levey. Sometimes you have an elderly person who could have a very low GFR and it could come to less than 60. So how do you differentiate between somebody who's got CKD and an elderly individual who's got a GFR of less than 60? And would you say that he has CKD, or his GFR may be lower than 60? And so that's a little bit of a confusion that I've always found. What is the opinion and what is the advice?
The guidelines don't specify any difference in the criteria for CKD for older individuals and for younger individuals. We do recognize that GFR goes down with age, but the definition is not age stratified. We think this is most consistent with public health measures for other diseases that are cardiovascular risk factors, such as hypertension, hypercholesterolemia, diabetes, and obesity, in which there's all an increase in the prevalence of those conditions with age, but there's no age stratification in the definition. So if the GFR is less than 60 in an elderly patient, we call that CKD. I think it's very useful to tailor the evaluation, management, and recommendations according to the patient's risk. And once we have a GFR less than 60, the KDIGO recommendations are to stratify the risk. And the best tool to stratify the risk is the kidney failure risk equation, which is based on GFR albuminuria, age, and sex. And for elderly, this predicts the risk of kidney failure in 2 to 5 years. And for elderly individuals without albuminuria and GFR near 60, the risk for kidney failure is very low. At the same time, the patients may need other treatments, such as appropriate adjustment for drugs, cardiovascular risk factor modification, and other factors, but we call them CKD, and that's currently what the guidelines do. But I think you can help the patient and yourself by estimating their risk for kidney failure. Indeed, if the albuminuria is very low, their risk for kidney failure is low, and their treatment would have to do with factors of taking care of things other than risk of progression to kidney failure.
Thank you so much. It's very clear. Thank you so much, Professor Levey.
Thank you, Prof. There's one question coming in from the chat. In a recently published data, early identification and intervention of chronic kidney disease, conclusions from the KDIGO Controversies Conference, the conclusion 5 actually reads that accurate GFR estimation includes both creatinine and cystatin C measurement for initial diagnosis and staging. What is your take on this, considering the African context?
I think I'm trying to remember which conference this could be from. I think the guidelines continue to stress initial evaluation using creatinine and confirmation using cystatin, or use of cystatin if we think creatinine might be inaccurate. In the United States, and I think in most of the world, creatinine is part of the basic metabolic panel or the comprehensive metabolic panel. So almost anybody who gets a blood test gets a serum creatinine. So I think our initial evaluation of GFR is always going to be based on the creatinine. And cystatin will be used selectively as a test for confirmation when there's some concern that the creatinine might not be accurate. I've shown you that there's a lot of imprecision in the creatinine, so we probably should have a lot of concern that creatinine may not be accurate enough. And those are the times to measure cystatin, but my strong recommendation is we'll never be throwing out creatinine. Any other test is going to be more expensive than creatinine because creatinine is so cheap. We should probably do a lot more cystatins than we're currently doing. I think it would, if we did 1,000 times more cystatins, it wouldn't be too many, but we'll always start with creatinine.
Thank you very much.
Professor, and I have one question. KDIGO recommend using CKD-EPI instead of MDRD, and the reason being MDRD actually tends to underestimate. But I don't know how significant it is in terms of that difference, because when I looked at the curve that you projected, it seemed there's a clear difference, yes, but I don't know how significant it is. On clinical practice, the difference normally, the number is 1 to 2 between when you calculate using CKD-EPI and MDRD using the same creatinine, then the difference is 1 to 2 in terms of the number. I don't know how significant it is from your presentation.
When the GFR is below 60, the equations give very similar estimates, and I'm sure that's what you're referring to in your clinical practice, where the difference is only 1 or 2. And of course, there's not a big difference if the difference in creatinine is 1 or 2. At the higher range, the difference can be, up to 10 or so. And in large populations, of course, this difference is significant with regard to risk prediction. It's significant with regard to classification of CKD versus non-CKD. And therefore, I think it's worthwhile. After all, the CKD-EPI equation uses the same variables as the MDRD study equation. So the only reason not to change is just inertia, right? it's just asking the lab to do a different calculation than they're currently doing. It doesn't have anything to do with cost or availability. So we should change. It doesn't make much of a difference for people with low GFR. If you don't use the CKD-EPI equation, you're not supposed to report the GFR as a numeric value over 60 because of that error. And I think it's worthwhile knowing whether the GFR is 62 or 92. So I would use the CKD-EPI equation. Of course, I'm biased. I developed the CKD-EPI equation, but you know, I developed the MDRD study equation 10 years before that. So maybe I'm biased in both directions equally.
Thank you, Prof.
I love that, Professor. Yeah.
Thank
so
you.
my question, I don't know, Engineer, do we still have some time?
Yes, we have a couple of minutes. I don't know, Professor.
I'm available. I got on late because of the time change, but I'm quite happy to stay on late if that's best for you.
All right,
All
thank
right,
you.
I have one question myself. My question, this is Robert. My question is around the development of the ethnicity factor. In my review, it seems like it was based on a very small population when the studies were done for African American coefficient. I would like you to shed a little bit more light on how that came into play, and it has been carried over the years. Of course, as you've shown, and as studies from Africa have consistently shown, that probably we don't need it for the Africans. The CKD-EPI works very well. And in fact, we haven't yet published our work, but we are consistently, again, we've looked at about 3,000 participants, measured their GFR using IXO, and it's showing the same things, that we probably don't need the coefficient to CKD-EPI, and it works better that way. But I would like to understand a bit more on the understanding around that development of that factor. Thank you, Prof.
Thank you, Robert. It's a very important question, and I'm following your work, so I look forward to seeing the results of the publications from your study. The proportion of North Americans who, particularly the US, of African Americans is about 13%. And in the MDRD study population, about 13% were African Americans. So we had about 1,800 people in the MDRD baseline data, and an appropriate proportion of African Americans, but it's not a large number. One of the reasons that the CKD-EPI collaboration was funded was to improve the MDRD study equation by increasing the number of African Americans, by increasing the number of people with diabetes, by increasing the proportion of people with high GFR, and by including kidney donors. For the CKD-EPI development data set, there were over 8,000 people, and 30% were African Americans. So that's about 2,400 people. So we have an excellent representation of African Americans. And the African American coefficient is 16% in that data set. That means that for the same serum creatinine, age, sex, and race, African Americans in that data set had a 16% higher measured GFR. Those participants also had a higher creatinine excretion, suggesting higher creatinine generation, perhaps due to muscle mass. And they had a lower creatinine clearance compared to the measured GFR, suggesting lower tubular secretion. Either of those two factors would account for the difference in GFR compared to creatinine that was observed in African Americans versus whites. We don't really know what the difference is due to, right? So I think it was well documented in the African Americans in that study. We're seeing the same thing in CRIC, if we look at the race difference in CRIC. But the differences aren't as big seen in African Americans and some other populations in our database, in particularly where there are fewer African Americans. And as you know, there's a big debate in the US whether the use of race propagates race-based medicine. And there's been a call for the elimination of the coefficient in the equations. We don't think it would be appropriate to just drop the coefficient, because that would be like using the equation calibrated for whites for blacks. But there may be some change in the equation for use in the US. For the moment, I think it's not an issue for Africa. You should just think that the African American coefficient pertains to African Americans, not to Africans. So I hope that extra detail is helpful to you. I know it's long-winded, but you get a chance to ask the expert, and I feel like I want to tell you as much as I can.
Thank you very much, Professor. Very much appreciated. There's one more coming in. They are asking about cystatin C has been with us for a while now, and yet routine is still not cost-effective. Considering the high variation of serum creatinine observed in our daily practice, what would it take to negotiate a cheap cystatin C assay?
I think probably the best thing to do to get cystatin available more cheaply is to order it more, but speak with your clinical laboratory director and have them bring the assay in-house. It's an automated assay. It can run on the big auto analyzers. It is more expensive, but it's not more expensive than BNP or troponin, which we use all the time whenever we think it's indicated. And I think the main problem is that if it's a send-out test and goes to another lab, it may not be covered by insurance to the same extent. It takes a long time to come back and it costs a lot more. So speak to your lab directors, tell them that you want them to bring this in-house, promise them that you'll order it more if they bring it in-house. You'll see the price come down, the turnaround time will improve, and you'll start seeing a big difference between eGFR, cystatin, and creatinine. And I think where you'll see it most are in people with muscle wasting. That's my clinical experience, where the GFR is too low in those sick old people. Excuse me, the creatinines are too low. The GFR estimates are way too high. And you'll see lower GFR estimates with cystatin. And those are probably the ones to be using on sick patients with muscle wasting.
Thank you very much, Prof. I think there's one more from Dr. Abdulaziz. Do you think screening for CKD in population is cost effective?
Great question. You know, there currently isn't a lot of data to suggest that it's cost effective. There were a couple of studies done more than a decade ago, probably 2 decades ago, that suggests for people with hypertension, it's cost effective if you have proteinuria, excuse me. It may be cost effective when there's proteinuria. There are no current recommendations to screen for CKD in the general population, but everybody says screen for CKD in high-risk groups, such as people with diabetes, hypertension, cardiovascular disease, hepatitis C, HIV. You see, I'm going on and on because we're now talking about checking for CKD in many patients who are under care for other medical conditions. And I think that's the most appropriate place for case finding.
Yes, I think the last one they wrote is, are there any improvements on the CKD-EPI equation that we should know about or something on the way? That's from Lloyd.
We've deliberately not changed the CKD-EPI equation for more than 10 years. I think we will probably end up releasing an equation that includes the blacks in the database, but doesn't include the black race term. I don't anticipate any changes to the CKD-EPI creatinine equation. with the exception of elimination of the race coefficient for use in the United States. I'm not sure that we'll have to wait and see whether that's accepted and whether people wish to use that new equation in places other than the United States. It won't be as accurate for whites. It won't be as accurate for blacks, but because we're worried in the US that it's difficult to ascertain race properly, it may be better to eliminate the coefficient. That will not, I don't think that should just be dropping the coefficient. It would be coming out with a new equation.
Yes,
so
I'm
sure you'll hear more about that.
Thank you. I think one more, I can't miss Professor Razin's question, is asking that, why do you think the Cockcroft-Gault equation is still being used in some quarters?
I think there are two reasons, mostly inertia. The second is that in 1998, the Food and Drug Administration of the United States suggested using the Cockcroft-Gault for pharmacokinetic studies. And therefore, a large number of drug studies were done with the Cockcroft-Gault equation, and many dosing guidelines are based on Cockcroft-Gault. The problem is that those no longer apply because the assay for creatinine in use at that time is not the same assay that we're using now. And the assay materials used for development of Cockcroft-Gault are no longer available. So the Cockcroft-Gault equation cannot be standardized for use with IDMS creatinine. So now all of our labs are using a different creatinine. And the creatinine, the CKD-EPI equation is meant to be used with that creatinine. The Cockcroft-Gault equation is not meant to be used with that creatinine. So even if you use the Cockcroft-Gault equation, you don't get the same creatinine clearances that they did back in the day when they developed the drug. The latest draft guidance from the FDA that just came out in 2020 says to use the estimated GFR and specifically cites the CKD-EPI equation. So hopefully we'll see some change, but it's hard to go back. So we'll never be able to redo those pharmacokinetic studies, but just understand that with the current creatinines, you're not getting the same creatinine clearances that we got back then. So there's no way to get it perfect.
Thank you very much, Professor. I think I'm going to have to ask the leaders, Dr. Nickel, to close the session, but we really want to appreciate you, Professor Levey, for taking time to share with us this wonderful information. You were a very great idol to some of us, especially working in the field you've worked in for 20 years. So it's been an honor to hear you speak and listen to your words of wisdom. And I'm sure this sentiment is shared by all my colleagues from across Africa and other parts of the world. Thank you very much.